Hello listeners, in this video you'll be learning about the contents of the thoracic wall. The thorax is the area between the root of the neck and the abdomen. The bony thoracic wall is made up of vertebrae posteriorly, the ribs, as seen here, as well as the sternum. The thoracic wall is important for protecting vital organs, including the heart and the lungs. The inferior reaches of the thoracic wall will also protect abdominal organs, such as the liver, drawn in here, and the spleen on the left-hand side. The thorax itself is divided into three main compartments. The centrally located mediastinum contains both the heart and the great vessels. And flanking the mediastinum on both sides are the pleural cavities, which are occupied by the lungs, as shown here in purple. The skeletal elements that compose the thorax include the sternum in the anterior midline, as well as the costal cartilages, shown here with the X's, and the 12 pairs of ribs that make up both the lateral and the posterior boundary of the thorax. Posteriorly within the midline, there are also 12 thoracic vertebrae, and you can see here a vertebral body interposed by two intervertebral discs, one above and one below. While the thorax is by and large a closed cavity, there are openings at the top and bottom of the thoracic cavity that allow for communication with other regions. The superior thoracic aperture, for example, is the kidney-shaped opening that allows the structures of the thorax to communicate with both the root of the neck as well as the upper limb. The superior thoracic aperture is bound by the first pair of ribs laterally and also bound by the manubrium anteriorly, as well as the vertebral body of the first thoracic vertebra posteriorly. There is also an inferior thoracic aperture through which structures pass to communicate with the abdomen. Here's the inferior thoracic aperture as shown here. The inferior aperture is much larger and is separated from the abdomen by the largest muscle of respiration, which is the diaphragm. Notice that the diaphragm attaches to the margins of the inferior thoracic aperture in all these areas shown by red. The sternum is the flat breastbone at the center of the chest, which is comprised of the manubrium, the body, and the xiphoid process. The word manubrium means handle. Whoever named the sternum thought it resembled a sword, with the body of the sternum forming the blade and the xiphoid process at the tip. At the top of the manubrium is the palpable jugular notch. When you palpate the jugular notch on yourself, it feels much deeper than it is in life because you're also palpating the sternal ends of the clavicles, which are seated within the clavicular notches. The joint formed by the clavicles in the sternum is referred to as the sternoclavicular joint. This joint happens to be a very strong joint in the body and is reinforced by the sternoclavicular ligament, as well as a ligament that is associated with the first rib. This is rib 1 here, and so this ligament that spans from rib 1 to the clavicle represents the costoclavicular ligament. On the lateral aspect of the manubrium is the first costal notch, which articulates with the costal cartilage of rib 1. Again, you see rib 1 located here. I'm going to draw a line to represent the area of the costal cartilage. This joint is referred to as a sternocostal joint. Sternocostal joints are an example of a synchondrosis joint, a type of non-synovial joint in which the bones are connected via hyaline cartilage. In this case, the hyaline cartilage is represented by the costal cartilages. The body of the sternum is much longer and thinner than the manubrium, and it has a scalloped lateral border because of the costal notches that articulate with the costal cartilages of ribs 2 through 7. At the inferior aspect of the sternum is the xiphoid process. The xiphoid process, throughout childhood and adolescence, persists as cartilage. Once an individual reaches early adulthood, the xiphoid process ossifies into bone. If CPR is performed on a patient too low along the anterior chest wall, the resuscitator could actually shear off the xiphoid process. This is actually quite dangerous for the patient because the sharp edges of the sheared bone could actually penetrate the thoracic wall and even penetrate the heart, causing severe problems. The xiphisternal joint, shown here, serves as a useful landmark for a variety of structures. For example, it represents the inferior border of the heart, it also marks the plane of the upper limit of the liver, and it marks the level of the central tendon of the diaphragm. All of these structures are in very close proximity to one another. At the manubriosternal joint is something that we refer to as the sternal angle. Notice the slight angle that is formed between the manubrium and the body of the sternum. This is referred to as the sternal angle of Louis. The sternal angle is a landmark for an imaginary plane called the transverse thoracic plane. This plane runs from the manubriosternal joint to the T4-T5 intervertebral disc. The transverse thoracic plane is a landmark where several structures make transitions. For example, here we have the trachea as shown in relief, and at the transverse thoracic plane, the trachea divides into a right mainstem bronchus and a left mainstem bronchus. Conceptually, this plane also separates the superior mediastinum above from the inferior mediastinum below. This same plane is also the transition point for the ascending aorta to become the aortic arch. Here's the ascending aorta with the X, and at the transverse thoracic plane, it transitions into the aortic arch. Once the aortic arch passes the transverse thoracic plane again, it changes names to become the descending thoracic aorta. In the case of the pulmonary trunk, we say that the pulmonary trunk bifurcates into the left and the right pulmonary arteries, as seen here just below the transverse thoracic plane. This same plane is also an area where the azygous vein will drain into the superior vena cava. I'll draw the azygous vein coming up here, making an arch, and the opening of that azygous vein will enter roughly at the transverse thoracic plane. In summary, the transverse thoracic plane is a transition point for a number of thoracic structures. The most common types of injuries to the sternum itself are usually crush injuries caused by traumatic events. Airbags have helped to significantly reduce the number of sternal fractures. However, sternal fractures can still occur in patients who have endured an automobile accident. Fractures of the sternal body are typically comminuted fractures, meaning the sternum has broken into several pieces. The radiograph on the left demonstrates a comminuted fracture of the sternal body. Interestingly, the mortality rate for individuals with sternal fractures is estimated to be about 25 to 30%, but this is not because of the fractures themselves. Rather, it's due to the secondary injuries the fractures cause. For example, the heart may suffer a myocardial contusion, a cardiac tamponade, or even cardiac rupture if the sharp edges of the fractured bone pierce the heart or the pericardial sac. Take a look now at the radiograph on the right. Do you notice any abnormality? This is an example of a dislocation of the manubrium from the sternal body. The manubriosternal joint is a non-synovial symphysis joint with no joint space or articular cartilage, meaning that no gap should exist on X-ray. In lab, after you have skinned the anterior chest wall, some tables may find a wire that is encircling the sternum. This wire was used to reunite the two halves of the sternum after a median sternotomy, which was performed to gain access to the thoracic cavity for open heart surgery, for example. During the procedure, the surgeon will make a midline cut straight down the middle of the sternum and then will place in retractors after the cut is made to separate the sternum and to gain access to the thoracic cavity. Notice that the cut is not made through the costal cartilages, shown here in yellow. This is because costal cartilages are made up of hyaline cartilage, which is very hard to repair. Bone is much better at repairing than hyaline cartilage. I'll also mention that the sternum is a prime site for taking a sample of bone marrow. During a sternal biopsy, a needle is used to pierce the cortical bone, which enters the trabecular bone where the bone marrow resides. The bone marrow sample can then be used to detect metastatic cancer, or can even be used to identify whether a patient is a candidate for donating his or her bone marrow to a relative or to a friend in need. The 12 pairs of ribs form the contours of the thoracic cage. Ribs are classified into one of three types. There are true ribs, false ribs, and floating ribs. The costal cartilages of true ribs articulate with the sternum directly. Ribs 1 through 7 are considered to be true ribs. Here you see the costal cartilage of rib 7 articulating directly with the sternum at the xiphosternal joint. However, ribs 8, 9, and 10 are all considered to be false ribs because they communicate with the sternum indirectly via the costal margin, as highlighted here by the red line. Ribs 11 and 12 are considered to be floating ribs. On their ends, they are capped by hyaline cartilage. Instead of articulating with the sternum, these ribs will terminate in the posterior abdominal wall musculature. The costal cartilages themselves are made up of hyaline cartilage, and they extend from the ribs and articulate with the sternum. When they articulate with the sternum, that joint is considered to be the sternocostal joint. Functionally, these joints contribute to the elasticity of the thoracic wall, which is important for respiration. Costosternal syndrome, also called costochondritis, is a very painful condition that is caused by either inflammation of the sternocostal joints or caused by subluxation of the sternocostal joints. Subluxation means partial dislocation. This particular condition is largely idiopathic, meaning that it has no identifiable cause. However, costochondritis can be associated with a benign tumor or with infection. Ribs 3 through 9 are considered typical ribs as they have all the following characteristics. The head of the rib is wedge-shaped with two facets, a superior articular facet and an inferior articular facet. These facets will communicate with the thoracic vertebrae. The neck of the rib is situated between the head and the shaft or the body of the rib. The costal tubercle has a smooth surface for articulation that communicates with the transverse process of the corresponding thoracic vertebra. Also notice that around the costal tubercle there are roughened areas. These roughened areas allow for attachment of the costal transverse ligaments, which you see here. These ligaments seat the rib against the transverse processes. Regarding the numbering of ribs, recognize that ribs articulate with the transverse process at the same corresponding vertebral level. So for example, if this represents the T8 vertebra, then this would represent rib 8, because this rib is articulating directly with the transverse process of T8. The shaft, also called the body of the rib, is very thin, elongated, and curved. The sharpest turn of the rib is known as the angle of the rib. The weakest point of any rib lies just anterior to the angle. Compressive traumatic injury, such as a football tackle, a car accident, or forceful CPR, can cause a rib fracture, leaving very sharp edges that can puncture nearby structures, such as the lungs, for example. Running along the inferior border of the shaft of the rib on the internal surface is the costal groove. This groove provides protection for an important neurovascular bundle that we'll see more of in just a moment. Together, the sternocostal joints anteriorly and the costovertebral joints posteriorly enable the bony thorax to be mobile. In general, you can think of the movements of the rib cage as being analogous to the movements of a bucket handle. Laterally, the rib cage will expand in diameter upon inspiration by elevating the ribs just like a bucket handle. When the bucket handle elevates, notice how the diameter increases laterally. This top image represents a baseline condition, and this lower image represents what the thorax would look like upon inhalation. Notice how much expansion has occurred in the lateral direction. Additionally, there is also an increase in the antero-posterior diameter of the ribs, because the ribs are moving from an obliquely oriented position to a more horizontal position during inspiration. As such, this allows for a greater diameter to be accomplished in the antero-posterior direction. Therefore, during inspiration, the elevation of the ribs in both directions increases the volume of the thoracic cavity. During normal expiration, the ribs will return to their baseline position. In the case of forced expiration, the thoracic wall will collapse even further beyond the baseline condition to help expel additional air that is retained within the lungs. Recognize that to achieve inspiration requires energy. That's because it is a very active process. As the muscles of inspiration elevate the ribs and increase the volume of the thoracic cavity, the diaphragm will simultaneously contract. Upon contraction, it will draw the lungs inferiorly, thereby creating negative pressure within the thoracic cavity. That negative pressure will help to draw in air through the trachea and the bronchial tree. In addition, the lungs are also expanding laterally, and that's in part due to their surface tension as they are in contact with the costal pleura, which is the inner lining of the thoracic wall. The large dome-shaped muscle is the diaphragm. This is the chief muscle of inspiration. It is also aided by other muscles, such as the external intercostal muscles, as well as the scalene muscles in the neck, especially during forced inspiration. Expiration, on the other hand, is a very passive process. Relaxation of the diaphragm will cause the diaphragm to rise within the thoracic cavity, thereby pushing air out of the lungs. Additionally, the ribs, with the help of gravity, will return to their normal resting position, which decreases the diameter of the thoracic cage and also helps to expel air. In the case of forced expiration, when you're trying to expel as much air as possible, like when you're trying to blow up a balloon, for example, intercostal muscles help to further collapse the rib cage to push air out of the lungs. Let's take a more detailed look at the muscles that contribute to the process of breathing, and let's begin with the star of the show, which is the diaphragm. The diaphragm is a dome-shaped musculotendinous partition that separates the thoracic cavity above from the abdominal cavity below, and again, it is the chief muscle of inspiration. In lab, when you remove the lungs, you'll see the diaphragm very clearly, and you'll be on the lookout for two important nerves. These nerves are called the left and the right phrenic nerves. These nerves are responsible for innervating the diaphragm. The phrenic nerves originate high in the neck from the cervical plexus, specifically from C3, C4, and C5 spinal nerves. As the saying goes, C3, 4, and 5 keep the diaphragm alive. On their course, the phrenic nerves enter through the superior thoracic aperture after riding along the anterior surface of the anterior scalene muscle in the root of the neck. Within the thorax, they course between the pericardium of the heart and the lungs, just anterior to the root of the lung. These nerves supply both sensory and motor innervation to the diaphragm. They're also carrying general somatic afferent fibers, which are sensory fibers from the pericardium of the heart and from the mediastinal pleura. The late Christopher Reeve achieved his stardom in his role as Superman in his early career. He also happened to be Robin Williams' roommate at Juilliard and lifelong friend. During an equestrian event, Christopher Reeve was thrown from his horse and he fractured his first and second cervical vertebrae, which caused severe spinal cord damage at the C2 spinal level. All motor and sensory function was lost from the C2 spinal level downward. So why then did Christopher Reeve require assisted ventilation for the rest of his life? Well, because the diaphragm is innervated by the phrenic nerves, which come from levels C3, C4, and C5. Since his paralysis occurred at the level of C2, no neuronal input was being conveyed to the levels below. Therefore, he couldn't activate his diaphragm for respiration. Because several structures of the thorax need to communicate with the abdomen, there are three diaphragmatic apertures through which these structures can pass. The caval opening, as shown here, is an aperture in the central tendon of the diaphragm at about the level of the T8, T9 intervertebral disc. Because the inferior vena cava is adherent to the margins of the caval opening, when the diaphragm contracts, it dilates the inferior vena cava, helping to return blood back to the heart. Through the esophageal hiatus, at the level of T10, courses the esophagus along with the vagal trunks and the esophageal artery. At the level of T12 is the aortic hiatus. The descending thoracic aorta emerges through this hiatus and changes names to become the abdominal aorta, as seen here. In addition to the aorta, splanchnic nerves and the thoracic duct also pass through the aortic hiatus. Unlike the inferior vena cava, the aorta is not subject to disrupted blood flow when the diaphragm contracts. That's because the aorta is considered to live behind the diaphragm and is not attached or adherent to the margins of the aortic hiatus. We'll see all of these structures in more detail when we get to the posterior mediastinum. The muscles of the thoracic wall assist the diaphragm during respiration. The intercostal muscles occupy the 11 intercostal spaces between the ribs and the costal cartilages. The intercostal spaces are widest anterolaterally, and they widen even further during inspiration and/or during lateral flexion of the vertebral column. This is clinically important for placing a chest tube. Before chest tube placement, you'll ask the patient to bend laterally in order to widen the gap between the ribs, and you'll also ask the patient to inspire to widen the gap as well. This makes the placement of the chest tube a little easier. The intercostal spaces are named according to the rib above the space. For example, this is the second intercostal space associated with rib 2 above. The exception, however, would be the space just below the 12th rib, which is referred to as the subcostal space instead of an intercostal space. Clinically, as you'll soon learn, certain intercostal spaces are important for auscultation. The second intercostal space is important for auscultating certain valves in the heart. Likewise, the fifth intercostal space can also be a prime location for auscultating heart valves. Before I leave this slide, I want to point out where the cuts will be made to remove the anterior thoracic wall. This, as a reminder, is a xiphosternal joint. This is going to be an important landmark for your cuts. You're going to cut transversely from the xiphosternal joint on both sides until you reach the mid-axillary line. The word axilla means armpit, so envision an imaginary line running down the center of your armpit. That's referred to as the mid-axillary line. You will take your saw and cut along that mid-axillary line superiorly until you reach rib 1. But don't forget, just above rib 1, the clavicles are positioned. So in addition to cutting rib 1, you'll also want to cut the medial 1/3 of the clavicle. Doing this bilaterally will allow you to remove the anterior chest plate in one piece. There are 3 muscles that occupy the intercostal spaces, and they are referred to as intercostal muscles. The outermost layer is the external intercostal muscle. Notice how the fibers of this muscle are oriented in an inferomedial direction. They are running both inferiorly and medially. I like to pretend that I'm wearing a hooded sweatshirt, and when I place my hands into the pockets of that hooded sweatshirt, the direction of my fingers represents the fiber direction of the external intercostal muscles. If you keep your palms planted on your rib, for example, but then curl your fingers upward, the action of the curling of your fingers represents the movement of the rib below coming upward toward the rib above. That means that the external intercostal muscles are responsible for elevating the ribs during inspiration. The second layer is referred to as the internal intercostal muscle. Notice the fiber directions of this muscle run approximately perpendicular to the fiber direction of the external intercostal muscle. If we go back to the analogy of having my hands in my pockets, now let's stick our thumbs outward toward our sternum. By sticking our thumbs outward, that represents the fiber direction of the internal intercostal muscles. Again, if you keep your palms planted against your chest and now curl your thumbs downward, This represents the movement of the internal intercostal muscles, in which case it is taking the rib above and moving it closer to the rib below. Therefore, the internal intercostals are responsible for depressing the ribs during expiration, specifically during forced expiration. The innermost intercostal muscles attach to the inner surface of the ribs, and they are the deepest layer of muscle. They too will function to help depress the ribs during forced expiration, so they have the same function as the internal intercostal muscles. Living between the internal and the innermost intercostal muscles within the costal groove is a neurovascular bundle. This bundle consists of the intercostal vein, artery, and nerve, in that particular order. We will sometimes refer to this as the VAN or the VAN relationship. We'll see this relationship in other areas of the body as well. Notice how the intercostal nerve is positioned at the inferior border of the upper rib. Clinically speaking, this is important for chest tubes and for needle thoracenteses. When inserting either a chest tube or a needle thoracentesis, you want to place the needle or the tube along the superior border of the inferior rib. This is important so that you avoid hitting the neurovascular bundle. The external intercostal muscles occupy the intercostal spaces from the tubercles of the ribs posteriorly, roughly in this location here, to the costochondral junctions anteriorly. Here's a true costochondral junction, and notice how close the external intercostal muscles are to these junctions, especially in the lower aspect of the thorax. On the anterior thoracic wall, the muscle fibers of the external intercostal muscles are replaced by a translucent membrane, which we'll call the external intercostal membrane, through which the fibers of the internal intercostal muscles can be visualized. Similar to the external intercostal muscles, along the posterior thoracic wall, there is an internal intercostal membrane. This membrane lives between the vertebral column and roughly the angles of the ribs. The external intercostal muscles can be visualized through the internal intercostal membrane. Here are the fibers of the external intercostal muscles as visualized through the membrane, which has been removed in the areas where I just marked with the pin. Notice also that the intercostal nerve is going to be positioned just deep to the innermost intercostal muscles, but will be superficial from this perspective to the internal intercostal muscles. So it's sliding between those two groups of muscles. When you remove the chest plate and turn it around to look at the deep surface, you'll visualize the transversus thoracis muscles. These muscles radiate outward from the sternum and attach near the costochondral junctions. The transversus thoracis muscles are weak muscles of expiration, and they also anchor the internal thoracic vessels to the chest wall. So here I'll draw in the internal thoracic artery. These hashed lines represent the fact that this artery courses deep to the transversus thoracis muscles from this perspective. And then here near the costal margin, the artery bifurcates into two smaller vessels. Here again, this is the internal thoracic artery. And it bifurcates into the superior epigastric artery. As well as the musculophrenic artery. In this image, we can also appreciate the two coverings that line the internal thoracic wall. The endothoracic fascia is a layer of loose connective tissue that forms a cleavage plane for separation between the costal pleura and the thoracic wall. The innermost membranous covering is the parietal pleura that lines the pleural cavities. Here's the parietal pleura. And lastly, I'll mention during dissection, you may find a grouping of lymph nodes. These are called the peristernal lymph nodes, and they live just deep to the transversus thoracis muscles alongside the sternum. These lymph nodes are responsible for draining the deep portion of the breast, for example. Recognize that parietal pleura lines the pleural cavities. The parietal pleura can take on more specific nomenclature depending on the surfaces it lines. For example, when the parietal pleura arches over the apex of the lung, it's referred to as the cervical pleura. The word cervical means neck. Therefore, this pleura reaches upward into the root of the neck. The majority of pleura is referred to as costal pleura because it lines the surfaces of the ribs, specifically lines the inner surfaces of the thoracic wall. The mediastinal pleura is going to line the surface of the mediastinum, which is positioned more centrally in the thorax. And lastly, the pleura lining the top of the diaphragm is referred to as the diaphragmatic pleura, shown here in blue. This pleura will also be continuous with the mediastinal pleura and will be continuous with the costal pleura in the costodiaphragmatic recess. Because parietal pleura is innervated by both intercostal nerves and phrenic nerves, that means it's sensitive to pain. A condition that causes pleural pain is pleuritis, also known as pleurisy. This inflammation of the pleura makes the surfaces of the pleura very rough, resulting in excess friction during breathing, which can be detected upon auscultation. Also realize that the pleura are composed of layers of mesothelial cells that are responsible for secreting serous fluid. You know those late-night commercials. If you or a loved one has been exposed to asbestos and been diagnosed with mesothelioma, call 1-800... Mesothelioma is a malignancy of the mesothelium, and it's often associated with asbestos in particular. So when you hear those particular commercials, that's what it's referring to. So how does the thoracic wall receive its vascular supply? Well, the internal thoracic artery, also referred to as the mammary artery, is going to arise from the subclavian artery in the root of the neck. From there, it will course inferiorly alongside the sternum between the costal cartilages and the transversus thoracis muscles. And it will terminate here near the costal margin as the musculophrenic artery and as the superior epigastric artery, as shown here. The superior epigastric artery will continue inferiorly to supply the muscles of the abdomen. Arising laterally from the internal thoracic arteries as well as from the musculophrenic artery are a series of smaller vessels which are referred to as the anterior intercostal arteries. These arteries run within the costal grooves toward the mid-axillary line, and once they reach the mid-axillary line, they're going to anastomose with the posterior intercostal arteries, which happen to arise from the descending thoracic aorta. And by the way, the word anastomosis simply means a connection between two tubular structures. So in this case, the anastomosis between these vessels allows for collateral circulation in the event that one of these arteries is occluded. And lastly, as a reminder, there are veins of the same name that accompany these arteries. The anterior intercostal veins, shown here, are going to drain directly into the internal thoracic vein. The internal thoracic veins on either side of the sternum will drain superiorly into the brachiocephalic veins, as shown here. Here's the right brachiocephalic vein. The posterior intercostal veins, however, shown here, are going to drain into a system of veins which we'll refer to as the azygous system of veins. You'll learn more about this in another video. Here's a look at a single intercostal nerve and all of its branches. Let's begin at the spinal cord. Emerging from the spinal cord are dorsal and ventral roots. These roots merge to form a single nerve called a spinal nerve. This spinal nerve quickly divides into a dorsal primary ramus, which heads towards the back, and a ventral primary ramus. Once the ventral primary ramus enters the intercostal space, it changes names to become the intercostal nerve. And the ventral ramus of T12 we'll simply call the subcostal nerve because it runs beneath the 12th rib in the subcostal space. Not only do intercostal nerves supply motor innervation to the intercostal muscles, but they also carry sensory information from the skin. Notice the lateral and anterior cutaneous branches of the intercostal nerves. These nerves are carrying sensory information from a certain area of skin that we'll refer to as a dermatome. Intercostal nerves 7 through 11 continue onward to the abdomen between the transversus abdominis muscle and the internal oblique muscles, and once they cross the line of the costal margin, they change names to become the thoracoabdominal nerves, which again are responsible for innervating the muscles of the abdominal wall, in addition to the intercostal muscles while they were in the intercostal spaces. The image on the left represents the dermatomal distributions throughout the body. A dermatome is an area of skin that is supplied by a single spinal nerve. The intercostal nerves segmentally supply the skin over the intercostal spaces. So if you can identify which intercostal space you're at, you'll also know the dermatomal distribution of that space. There are a couple of key landmarks to point out. The first of which is the nipple, which represents the T4 dermatome. The second is the umbilicus, which represents the level of the T10 dermatome. Let's suppose that you have a scratch right here in the third intercostal space. The pain felt from that scratch would be conveyed through the third intercostal nerve, which is associated with the T3 spinal nerve. Information would be conveyed back through the dorsal root ganglion and back to the spinal cord. A relatively common condition that often involves intercostal nerves and affects the skin of the thorax is referred to as shingles. Shingles is the adult version of chickenpox, in which the herpes zoster virus has been lying dormant within the dorsal root ganglion, and when it becomes reactivated, it causes a rash that follows the dermatomal distribution of the affected spinal nerve. That rash is oftentimes very itchy and very painful. So in this particular example, in this patient, we see a rash originating in the lower reaches of the thorax, wrapping around toward the umbilicus. Assuming that this is at the level of the umbilicus anteriorly, then we can make the assumption that the T10 spinal nerve has been affected. Thanks for watching. Happy studying.